welcome to our first Zoom webinar of 2022, A Culture of Care, How to Prevent and Manage joining us from a place where you are able to pay attention and focus on our webinar. A few housekeeping items as we start today. All participants are kept on mute throughout the duration of the presentation, and you can use the chat function for any technical issues. And we're hoping you can use the chat function right now to tell us where you're joining from today. We want to hear about all the great states and places that everybody's joining us from. So let's use the chat function and welcome everyone and tell us where you're joining from today. As you're doing that, I'll let you know that we will use the Q&A for any questions you may have, and we'll be monitoring the Q&A. For those of you that are familiar with Zoom, you can vote on Q&A questions to move them up on the radar, so you don't have to type the same question as one of your fellow attendees. You can vote on them and vote them up with the thumbs up arrow. We are recording this webinar, and we'll be sharing the recording with you in our follow-up email in the next few days. There is a survey that pops up at the end of this webinar. You are highly encouraged to take it, not only to give us feedback on the webinar itself, but also for those of you that are claiming continuing education today. We know how important those CHES credits are for all of you joining us from the CHES community. That's how we are able to issue your continuing education credits. So make sure that you complete the survey, and we'll remind you again towards the end of the webinar. So thanks again for joining us and letting us know where you're from. A little bit about our program. Healthlinx is a public health, the signature public health outreach program of the Center for Health, Work, and Environment. We're located at the Colorado School of Public Health on the Anschutz Medical Campus of University of Colorado in Aurora, Colorado. I'm joining you today from my home in Denver, Colorado. I'm David Shapiro, and I am a program manager at the center. My pronouns are he, him. I am a white male, and I'm joining you today with a gray sweater on, and I'm wearing a beard, and I have glasses. So thank you everyone for joining us in today's webinar. We are one of 10 centers of excellence funded by the CDC to talk about total worker health. And if you don't know a lot about total worker health, it is basically the idea that employee health and safety are intertwined. It's really important to focus when we talk about worksite wellness strategies on both the health and safety of your team members. And we're part of a team of researchers and academicians here at the Center for Health, Work, and Environment, and science and evidence informs everything that we do. So I'd like to acknowledge, as we gather today in this virtual space, that we honor and acknowledge that the University of Colorado's 4 campuses are on the traditional territories and ancestral homelands of the Cheyenne, Arapaho, Ute, Apache, Comanche, Kiowa, Lakota, Pueblo, and Shoshone nations. Further, we acknowledge the 48 contemporary tribal nations historically tied to the lands that comprise what is now called Colorado. Acknowledging that we live in the homelands of Indigenous peoples recognizes the original stewards of these lands and their legacies. And with this land acknowledgement, we celebrate the many contributions of Native peoples to the fields of medicine, mathematics, government and military service, arts, literature, engineering, and more. We also recognize the sophisticated and intricate knowledge systems Indigenous peoples have developed in relationship to their lands. We recognize and affirm the ties these nations have to their traditional homelands and the many Indigenous people who thrive in this place, alive and strong. We also acknowledge the painful history of ill treatment and forced removal that has had a profoundly negative impact on Native nations. We respect the many diverse Indigenous peoples still connected to this land. We honor them and thank the Indigenous ancestors of this place. The University of Colorado pledges to provide educational opportunities for Native students, faculty, and staff, and advance our mission to understand the history and contemporary lives of Native peoples. With that being said, We're going to talk today about the impact of chronic disease on the workplace. We are going to have some brief remarks that I will continue with to set the stage for our conversation, and then we'll turn it over to our esteemed panels. Today, we have 4 terrific panelists joining us from a variety of fields that are really going to help us provide context to what it means to prevent and manage chronic illness in the workplace. And then, as always, we will have a Q&A session where all of you as participants can ask questions of myself or of our panelists, and we encourage you to use the chat function just for technical issues but really put any questions that you have in the Q&A box. And as I mentioned before, you are able to vote up questions. If you have the same question as a colleague, don't feel like you need to type it again. You can use the thumbs up to provide sort of more oomph, if you will, to their question. So why chronic illness? The field of public health talks a lot about health promotion. We talk about occupational safety, but really ongoing chronic illness is affecting, nearly 60% of Americans. And more people in our country are living not only with chronic illness, such as diabetes, cardiovascular disease, or cancer, but with multiple conditions. And there are disparities that occur in chronic illness based on our race, based on our background, based on socioeconomic factors, and the social determinants of health. And we want to honor and acknowledge that chronic illness does not affect all of us in the same way. And it's been forecasted that by the year 2023, the top 7 chronic illnesses in the United States are projected to have a total impact of nearly $5 trillion. It's kind of hard to even put that type of number in context in terms of treatment costs and lost economic output. When we talk about public health, and I want to put this in context here, that we're talking not only about preventing chronic disease, but also managing them. But we really talk about prevention in terms of the hierarchy of prevention, which you're seeing here on your screen. Primary prevention is health promoting behavior and health promoting activities. And it's really the most cost-effective way to mitigate the effects of chronic illness is primary prevention techniques. Secondary prevention includes screening, which is really important to understand individual risk factors. And then treatment or management of chronic disease is what we would call tertiary prevention. It is still in the prevention bucket, but really we're talking here about managing individuals that have a already diagnosed chronic disease. So I just want to put that in context for you all, that we're talking about both prevention and intervention when we're talking about how workplaces can address and handle chronic disease. And our charge as a Center of Total Worker Health and as public health advocates is to have you work not only on intervening for individuals that are experiencing chronic illness, but also through your workplace well-being program, through your commitment to total worker health, to really focus on how the workplace can be a bastion for preventing some chronic disease and keeping people healthy. In fact, maybe even sending them home healthier than they came to work, if that's possible for you to imagine. And prevention really matters. We know that there are 6 identified modifiable risk factors. And before we begin talking about the cost and the prevalence of chronic illness, there is good news. There's a handful, and there's probably more that you all as health educators and public health advocates could add to this list, but there's a handful of modifiable risk factors that can significantly reduce the prevalence of chronic illness. And they can help those who have already been diagnosed to live healthier and better manage these conditions. I'm not suggesting that this is easy. As we all know, lifestyle change and habit formation are hard and they take time. And that said, if through your workplace wellness program, you can find ways to help your employees incrementally reduce their risk factors and feel supported to do so, it will impact your productivity and the direct healthcare costs. And so what we have listed here are CDC's recognized modifiable risk factors that really should be included. Most of them, multiple of them should be included in any evidence-based worksite wellness program. So we're going to pause here for a polling question, and we're going to ask you all, how focused do you feel like your organization is, your workplace, on preventing chronic illness? So my colleague is going to launch a poll here, and on a scale of 1 to 5, let us know where you feel like your organization is on preventing chronic illness. We'll give you all a few moments to respond to this poll question. And Madison, I'll ask you to monitor how the poll is going and close it when you feel like we've had several responses. Great, thank you so much. So looks like maybe middle of the pack, mid-tier here. So I'm impressed that a number of you are saying it's a top priority in your wellness program. Some of you are saying a small percentage, not at all. And the bulk of us are sort of in the middle tier, that maybe it's not a core value, but it's something that the organization is focused on. So to some degree. So we appreciate you providing us that context as we get started today. So let's switch over and talk a little bit about what exactly we mean by chronic illness, chronic conditions, or chronic diseases. We sometimes interchange those words. Today, we're going to go with chronic illness. These are conditions that last for at least 1 year and either require ongoing medical care or they limit your daily activity. What we know is that 6 in 10 adults in the US have a chronic illness. And 4 out of 10 are diagnosed with 2 or more chronic diseases. And that's really important for us to understand. There's been a lot of research that has come out through COVID as well, that individuals experiencing chronic illnesses suffer more greatly and have more severe side effects from contracting COVID. And the research has been clear on that as well, that underlying chronic illness and co-occurring illness and disease is really something that we need to watch out for and help people manage. We know that through conventional wisdom, that healthcare expenditures follow the 80-20 rule, or about 80% of your organization's healthcare costs are driven by about 20% of your population. So managing multiple chronic conditions is a big reason why, as employees, employers are faced with higher cost medications, hospitalizations, and treatments as their care becomes more complex and harder to manage. We're going to hear a little bit more about how to manage chronic conditions and specific strategies through some of our panelists today as well. And so another factor in here to recognize, we know that one chronic condition that often doesn't get brought to people's attention is joint pain and osteoarthritis. Individuals with almost a third of individuals with osteoarthritis have 5 or more chronic conditions on this list. So really impacted by so many of these chronic illnesses. Some facts that we also know about chronic illness. Once again, big numbers here. 90% of the nation's almost $4 trillion in annual healthcare expenditures can be contributed to the care of chronic disease. And by 2023, as I mentioned earlier, the top 7 chronic diseases in our country are projected to total nearly $5 trillion in treatment costs. Hard for us to sort of even put those numbers in context. 5 of the chronic diseases or risk factors, high blood pressure, diabetes, smoking, physical inactivity, and obesity, cost US employers, and this is a big number as well, $36.5 billion a year just in missed work. This is in sort of facts that we know from missed days of work and studies on workers in America and how many days of work per year they're missing based on the chronic illnesses that they're encountering and that they're diagnosed with. So when we talk about your total worker health or your worksite wellness program, I just wanted to sort of put this out here. This is another example of prevention to intervention model. A lot of wellness programs are talking about behaviors and behavior change. And so the general health and well-being program, the general wellness program, may look at individuals with no risk factors or few risk factors, and you're still getting them to participate more in what other health behaviors you're looking at. Then there's programs that, in addition to focusing on the general wellness categories, are going into chronic illness management. So individuals with a few complications, maybe in terms of needing some accommodations of how they work and where they work. And oftentimes organizations are looking at even, and we'll see this today, having on-site clinical or medical clinics, as well as access to telehealth services for individuals that are diagnosed and understand that they have a chronic illness. Now, case management, major complications, that's probably a small percent of your wellness program. Clearly, individuals in this category need additional support from the human resources team, from perhaps accommodations and the Americans with Disabilities Act. But I'd say the focus of most of the health and safety programs that we work with in Healthlinx are in the first two buckets here: wellness behavior change and chronic illness management. Diagnosed conditions with major complications are obviously complicated, and something between the patient and the doctor to figure out how work is a part of all that. What we know is individuals who work overall are healthier no matter what their chronic condition is. So the idea is keeping people at work and at their job as long as for as much as possible. And with that, we're going to launch our second poll today. So thanks again to the Healthlinx team and Madison for launching our second poll. We're going to ask you here now about managing chronic illness. So once again, on a scale of 1 to 5, how focused do you think your organization is on managing chronic illness? So we had prevention first, and now we're going to talk about the management of chronic illness. Thanks again, everybody, for participating in the poll. Similar results. I think one thing I'm noting here from the first one is more organizations are at a 1, saying that their organization does not at all focus on managing chronic illness. That percentage doubled from our first poll. We still have the bulk of individuals in the middle tiers here. And then I think the number in 5, that it's a main focus of the organization, went down a little bit as well. So thanks again for engaging with us in this way. And with this, I'm going to start to introduce our panelists for today. And we're going to start, I'll introduce the panelists one at a time and then let them introduce themselves and make a few remarks on their topic of interest. And as you're listening to them, be thinking about questions for the Q&A, or even start posing them in the Q&A. We'll be moderating that. So first, I'm honored to introduce Dr. Cheray Watkins. Dr. Watkins is a certified clinical psychotherapist and coach with over 10 years of experience in mental health and substance use counseling, chronic disease and chronic pain, and sexual assault advocacy. She currently serves as the Director of Wellness Counseling and Assistant Professor in the Department of Behavioral Sciences at American University of the Caribbean School of Medicine in St. Martin. A leader in the mental health and substance use field, Dr. Watkins' passion is to transform systems that perpetuate decreased access and utilization of counseling and addiction services to marginalized populations. As a highly sought after presenter and keynote speaker, as well as author of Healing in Review, she's dedicated to sharing the tools and knowledge her readers need to live happier, healthier, and more fulfilling lives. Dr. Watkins currently resides in St. Martin with her husband, Lorenzo, and 2 boys, William and Bryson. So thank you, Dr. Watkins, for joining us today. And please tell us a little bit more about your work and research. And as I mentioned earlier, we know that chronic illness does not affect all of us the same way. And we'd love for you to set the stage and provide some context about how additional communities experience chronic illness.
Thank you, David. Good afternoon, everyone. My background prior to becoming a clinical psychotherapist, I was actually working as a certified health education specialist, initially as a generalist, and then my specialty, of course, is working with sexuality. However, over the course of my tenure of employment, from prevention now to treatment on the counseling side, my interest has always been working with marginalized populations. And so over the last 12 years, I've worked with various different types of patients living with HIV and AIDS, sickle cell and hemophilia, lupus, and typically the intersection of comorbidities of sometimes both. And what I've learned in working with these populations is that chronic illness or chronic disease does not look the same when it comes to many minority populations. Some things to consider. Let's look at chronic illness and how it typically shows up when it comes to minority populations. We know that typically the onset is about the same across all races. However, when we're looking at the data and digging a little bit deeper, the onset, as far as when they enter into medical care, they're more likely to be at a higher severity compared to their non-minority counterparts. And so by the time they're entering into the medical for medical treatment, they have higher symptoms, they're more severe, more profound. And so their trajectory when it comes to disease management is more complex and difficult compared to those who are not minority. And then we have to look at the second part, which is that we have to look at this intersection of minorities and chronic illnesses and the social determinants of health. We know that all these different factors such as housing, community, education, socioeconomic status, all are contributing factors. And so when we're looking at how do we prevent and then also manage chronic disease among minorities, it's not going to be what we call a one faceted or cookie cutter approach. We are now moving towards the use of this term called the syndemic, meaning that a syndemic is a set of linked health conditions that not only just interact with one another. So we're talking about chronic disease and maybe also mental health. We also know that it has an interaction and also a contribution to the access burden of this disease. So when we're looking at minority populations in the workplace, when it comes to chronic illness, typically when we're looking at the research, they're more predisposed for comorbidities. They're more predisposed typically when it comes to mental health issues. And so we have to look at the whole person. And so some questions that you can ask yourself within your facility, with you as a specialist, is what does your program look like? Who's at the table making the decisions? And are you all being creative, culturally sensitive, and equitable in the types of programmings that you are providing when it comes to minority populations? Typically, one thing to consider is that minority populations would try different types of interventions and activities. However, we know that from a therapeutic viewpoint, they're very much a narrative type of people. And so the use of your traditional approaches also can be linked and collaborated when it comes to some non-traditional approaches, where we have the use of narrative therapies that will also typically may lean more towards minority populations. Also, we want to lean towards best practice, but we also have to look at the but to that also. Who created the best practice? Were minority people at the table? And so we also can take a step back to say, yes, we need to use programs that have been validated, but we also have to look at who validated the data, who was a part of that research, because many minorities are not a part of the research process due to historical trauma. Third, the last thing to consider is that when you're also delivering your workplace surveys when it comes to minority populations, is did you disaggregate the data? Which is very, very, very important. Because if you're surveying your workplace, and regardless of the size of your workplace, if you're not able to dig deeper into what your minority employees are saying, you may see a problem or may not be able to see a problem. So let's give an example. When COVID hit, a lot of workplaces sent out surveys saying, hi, everyone, we know that this is a difficult transition. Everyone's moving to isolation, working from home. How are you? Just a very open-ended question, and it may have asked about physical health, mental health, or whatever. However, when we dug a little bit deeper, we saw this research saying more likely to have increased symptoms of mental health, such as depression and anxiety. Did you look specifically deeper at some of the additional questions, or did you ask the additional questions that you should have for those minority populations? Because minority populations, when we're looking at COVID and mental health and those types of things, the core, or sometimes what we call the root of it, is slightly different compared to other races. Many minorities are trying to juggle the complexities of wearing many different types of roles and also many different types of masks. And so we have to be mindful of the types of surveys that we're given and dig a little bit deeper into the research.
Thank you so much, Dr. Watkins. Really important context there about how to analyze data and how chronic illness is connected with mental health and affects our communities in different ways. As a reminder to everyone, as we continue to introduce and speak with our panelists, please post any questions you have as things come up in the Q&A section. Vote on them to move them up, and we will be moderating those questions coming up soon here as we go and speak with each of our presenters and our panelists. I want to move on and welcome Stephen Halterman. Steve is the Workforce Wellness Manager for the state of Colorado, and in that role, he develops innovative and evidence-based health management programs for the workplace. He is a Master Certified Health Education Specialist, a Certified Employee Benefit Specialist, and a Chronic Care Professional Registered Health Coach. Before his time at the state of Colorado, Steve served as a behavioral health clinician and health educator. Focusing on the full continuum of care, he worked to improve and measure patient outcomes. And throughout his career, Steve has helped ACOs, primary care clinics, healthcare systems, and employers develop and manage various population health improvement programs. Steve holds a master's degree in public health from the University of Texas and a Bachelor of Arts in Business Communication from Baruch College, CUNY. So thank you, Steve, for joining us today. Let's sort of dig into context here a little bit. Tell us a little bit about your role at the state of Colorado. And I know you'll mention the State of Health program that you've been working so hard on launching and starting with the first cohort. How are you and how is the state of Colorado approaching the prevention and management of chronic illness?
Yeah, thanks, David. Well, the thing is, there's this status quo that's been around for a while, perhaps about, I don't know, 10, 12, 15 years, where employers have moved away from disease management programs and toward wellness programs. I know it's in my title, but I don't like to use the term wellness. At the state, we have offered wellness programs, traditional status quo, incentive-based wellness programs. And that's, I'll say that approach is kind of like wellness for all, right? It focuses on, hey, let's give everybody the opportunity to be well, but it's so limited in its ability to reach those who actually need to improve their health. It tends to favor those who are already healthy. And we know now that, well, today we're in the COVID era. And, so what is different for employee benefits and wellness in the COVID era? I'm going to say just a few things. COVID, we have it. It's going to be around for a while. Social justice, the social justice movement that's happened in the past few years has measurably changed priorities for employers. And then the virtual environment. So healthcare is now delivered virtually in many settings. Digital health is now becoming the thing to do because we can reach more individuals from a virtual perspective. So what do we do at the state? The state brought me on about back in 2020, and I've developed programs for other employers. It's really exciting to be at the state of Colorado. We have a workforce of about 35,000 employees covered under our two health plans. One is with Cigna, and we have Everside as our primary care provider, and the other is with a vertically integrated healthcare system, Kaiser Permanente. So two different approaches, but trying to achieve the same goal. So we developed State of Health as an effort to really help engage those employees. Well, it is wellness for all, but primarily it is helping those employees to identify their risks and to, one, prevent chronic conditions, two, manage chronic conditions, and three, when possible, reverse those chronic conditions. And so, disease management is not, that doesn't sound nobody wants to be a part of disease management. So we like to say, hey, you have chronic conditions, you can recover from those conditions in many situations. So we developed this program. It's based on three real principles with the evidence base. So one, evidence-based treatment criteria. We're not going to put something into our program that we don't have an abundance of evidence saying this works in this setting. Two, structured and clinically integrated wellness and primary care. That's something I haven't seen many employers do, which is wellness, health coaching programs integrated so much that the health coaches and the primary care providers collaborate together. That's the those are two of the necessary elements, and having a structured program. So a lot of employers offer health coaching, right? It's ubiquitous across employers, but many of those programs are essentially ad hoc health coaching. Hey, what do you want to work on? Okay, yeah, I'll help you set your goals. Yeah, that's okay, usually for healthy people. But for someone who's been struggling with diabetes, obesity, tobacco use for years and years, it's a tall order. So we really work to, in our structured program, that's a year-long program, really start with needs assessment, risk assessment, help those individuals to develop an action plan. We have what we call the tandem session, which is the health coach and that primary care provider and the program participant or employee all participate in one virtual session like this, 3 people. And what's really great about that is an employee can really come out of that session feeling like, wow, my health coach, my provider, they're both helping me and supporting me with the plan that I created. And that's one of the best ways to really support self-efficacy. So anyway, I got a little bit into the clinical stuff too much, but we have a team now of 13. Well, we better add another one so it's not unlucky. 13 health coaches. We're planning to have 15 or 20 by the end of the year. We started the program in March of last year with 100 pilot participants. We enrolled another 100 pilot participants in the fall, and we've just enrolled 200 participants in the past month. So we now have 400 in the pilot, which we will measure. We measure everything. We start at the beginning. They go into the clinic, get a biometric assessment, A1C, lipid panel, the works. We do a health engagement assessment, kind of like an HRA, and a health status inventory, which the health coach does on an interpersonal level, really working with that participant to identify their unique needs and goals for health improvement, and then developing that action plan to really help those participants to engage in those things. David, you talked about 6 areas for a healthy lifestyle. And yeah, those are correct. I'd like to say everybody, 4 of those impact everybody. Okay, so the smoking and the drinking, they're very important, but they don't impact everybody. There's some people who don't drink, and now plenty of people who don't smoke. But nutrition, physical activity, stress and coping, sleep and rest, those are the areas that every human can continue to improve. And when we have chronic conditions, which many in our workforce have multiple chronic conditions, those become imperative to really not only getting your health care and working with your primary care physician, but doing the work. And to do that, we provide the support, social support, the structured program, skill groups that are really more designed as discussion groups. So I have one of those right after this. We're doing the nutrition skill group. I love doing those things, but really engaging those participants in, hey, what are your challenges with eating right? And what are the ways that you've been successful? What are some of your goals? And we just talk about it with a group, small group, 10 or less usually. So really those key ingredients make the program, give the program the opportunity to be successful. We've developed the program at the state, but we partnered with our healthcare partners, Everside, Cigna, Kaiser Permanente, and CSAP. Oh, so we have our own internal EAP, CSAP. They are great. And we've integrated the EAP with State of Health. 4 of our therapists who work for the EAP have now become certified health coaches, in addition to being licensed behavioral health providers. And they deliver the State of Health program, same thing that's delivered by Cigna, KP, and Everside, but with more of a focus for those who are really focusing on their anxiety, depression, tobacco dependence, while also working with them in a whole health perspective. So we do focus on that whole health integrated care team. One key thing that made it possible at the state to put this together is the collaboration. Believe it or not, from the public sector, we are not so siloed as one would think. So our employee benefits unit, our risk management, our EAP, we've all worked together, wellness, we've all worked together to develop this program, and it's a team effort that works throughout all our 50 agencies throughout the state of Colorado. So we're excited about it. Thanks for letting me share about it. I could go on for days, but you have other panelists, so I will cut it short. Thanks, David.
Thanks so much, Steve, and excited to hear more about the State of Health program. And we'll make sure as part of our follow-up email that we send a link to the State of Health program, which has its own website, both externally facing that participants are participating in as well. And we want to provide you additional employer context as well. And so we're going to switch over now, and I'm honored again to introduce my colleague, Emily Sharp. Emily is the Living Well Program Director for TIAA, leading all things employee health and well-being among the company's nearly 13,000 US-based employees. Emily earned her master's degree in health promotion and education from the University of Cincinnati, and she's currently enrolled in the Colorado School of Public Health's Total Worker Health Certificate program. In addition to her day job, Emily is the recently elected mayor of Elon, North Carolina, where she resides with her husband, Logan, daughter Lila Kate, and her dog Hobie. Thank you very much, Emily, for joining us today. And similar to Steve, we want you to provide context about how TIAA approaches preventing and managing chronic illness. So help us understand better your role and what TIAA does in that space.
Sure, thanks so much, David. So like David said, I'm the Living Well Program Director at TIAA, and like Steve, we don't really like to say wellness anymore. So we are living well. And my role is to oversee our associate wellbeing program and all of the offerings, except for those that are specific to the medical plan. So somebody else oversees like the administration of the medical plan, and I do the rest. So this includes our incentive program and strategy and design, our on-site Living Well resources, and oddly enough, our time off programs, because those have been wrapped into what we call Living Well. Of course, like Steve said, COVID has been a huge part of my role over the last 2 years. My team does support our efforts, our strategy, and then just helping employees if they are positive or have a family member as well. Just a little bit about TIAA, if you're not aware of what TIAA is. So we are a Fortune 100 financial services company. And our goal is really to be the change in the industry by delivering lifetime income for all, by making investments that build a better world. And so the company actually started as a retirement plan for teachers, with the goal of helping teachers to retire with dignity and helping them to achieve that. We've grown tremendously over the last 104 years, and now are open to anyone with over 5 million clients across the country. We are very much so a mission-driven organization. And, so everything that we do, including our Living Well program, ties back to our guiding principles, which include things like taking care of our people. So that's us as employees, but also our clients are our people. We act with integrity and we deliver excellence. And again, that's just part of who we are. It's part of our mission. We have about 12 to 13,000 US-based associates residing in all 50 states, including Hawaii, but I haven't been able to get there for our 3 employees. So I keep pushing for that. With nearly 75% of all of our employees being in our 6 hub office locations. So those locations are in Charlotte, Chicago, Dallas, Denver, Jacksonville, Florida, and then our world headquarters in New York City. So it's a lot across a large amount of land, I guess we'll say. We also have about 2,000 employees outside of the US, but they actually have their own wellness program offering and own person that oversees those. Our approach to associate well-being is really focused on this idea that to help our associates live well, because we believe it's the right thing to do. And we believe that when employees are healthy, that they're more productive, they're happier, and they can live a more fulfilled life in and outside of work. So we look at living well through a very holistic lens and consider all the facets of one's well-being. And this has really driven the way that we approach our Living Well offering, which includes those areas of comprehensive worksite wellness that David shared earlier on the slide around prevention, treatment, and management. Kind of the bread and butter of all that we do are our on-site services. So with so many of our employees in those hub locations, we've invested heavily in on-site services in those offices. So we have partnerships with Premise Health, Virgin Pulse, Walgreens, and Aetna. And through those partnerships, we maintain on-site primary care health centers and on-site pharmacy, on-site fitness centers, on-site healthy lifestyle coaches, on-site massage therapy, and on-site mental health counselors. And, while all of these resources are employed by various partners, we all act as a singular Living Well team to provide an integrated approach to care for all of our associates. And since I came on board 10 years ago, the way that we really approach this is through relationship building. So we believe that the relationships that are built in this setting of these on-site providers, at least for the majority of our employees, that when that relationship is built between the employee, or in this case, a patient, and their healthcare partners, that this is really an essential part of preventing and managing chronic illness. And so we do encourage the use of on-site services. It's not required, but we do encourage it. We promote it heavily. We incentivize use of the on-site services, and also those come at a lower or even no cost for care in many of those different services. Just one example of how this works in our favor and in the favor of an employee is that we know that employees who utilize the on-site services are more likely to control their A1C. So we look at, okay, this cohort of employees has a high A1C or has a diabetes diagnosis, for example. And then we know that those who seek care in the community versus those who seek care on site have better measures of control than those out in the community. And the same is true for blood pressure management. And then that high quality care that's offered on site also comes again at much lower cost to the employee, but also a lower cost to us as a company. So it's kind of a win-win. Of course, somebody's probably already asked in the Q&A, what do you do about the other 25%? So obviously they don't have the same ability to have that relationship with that person on site, but we do have a lot of virtual care offerings, and it's come really in handy over the last 2 years as more people are looking for virtual care and our workforce becomes, more remote and, more flexible in their location. Someone can be at the beach and still work, or someone can be in the mountains and still work. So we have partners with Aetna's In Touch Care program. Premise Health has a virtual care offering. Of course, our employee assistance program, our telephonic health coaches, and others. And then just to wrap up, we do review our offerings every quarter at minimum and every year to really make sure that everything that we're doing and offering continues to meet the needs of our employees. And while most of the nation continues to see rises in chronic conditions and costs related to them, so do we. But our costs and rates have actually increased at a much lower scale than that of Aetna's book of business, as well as the national averages. So we really look at that as a win, but of course, always looking at continued improvement.
Thanks so much, Emily. One thing I want to mention as we're drawing towards the top of the hour, unfortunately, we never get a chance to answer everybody's Q&A questions. So thank you for continuing to vote them on the scale. I'm noticing some questions that are related to specific strategies to change behavior and have people participate in the program, which is why I'm happy to sort of introduce our fourth panelist for today, Todd McGuire, who's going to talk to us a little bit about strategies for getting people to participate and engage in the wellness program or in the health and safety offering that you have. Todd is a health technology entrepreneur driven by the desire to help as many people as possible live a healthy life. He's the co-founder and chief technology officer for Denver-based Incenta Health, where he manages product development and technology strategy. Incenta Health offers weight management programs and a CDC-recognized virtual diabetes prevention program called #PreventDiabetes that uses an app-connected smart scale with visual progress tracking and behavioral economics to help people earn rewards for improving their health. The patented Healthy Selfie program creates an industry-first visual health screening that is enthusiastically embraced by members because they can see their progress visually. Todd has been awarded patents in the United States and Australia for remote biometric monitoring systems and data visualization technologies. A graduate of University of Colorado at Boulder, Todd studied information systems, organizational management, and human resources management to earn his BS degree. Todd is also a certified personal trainer, who used to enjoy participating in marathons and triathlons to stay healthy, but now just chases his 3 young children around an even more demanding form of exercise. So thank you, Todd, for joining us today and giving us a little bit of a hint. And we do want to make sure we're able to answer some Q&A about incentives and strategies for engaging people in the health and wellness program.
Excellent. Thank you for the introduction, David, and I'm pleased to be on the panel with everyone today. And I loved your comment to kick it off, David, of let's try to send the employees home healthier than when they arrived. I mean, I think that's a nice visual to kind of keep in mind. And what I want to take us through in the next few minutes is our view and kind of a neat model that I want to see if everyone can take advantage of, that is really a framework that we've developed over the last 20 years of just implementing behavior change programs in employers, health plans, for health departments. And one of the things you'll see in this model is trying to align the health benefits that we're all talking about today with the business benefits as well, so you can really get at sustainability and get it truly aligned with everything your organization is trying to do. So the model is up at the top of the bio slide that David has up. And it's just simply called the 4 R's. And there's a sequence to it. You know, it's moving in a specific order, and each one of these builds on the one before it. And together, they really kind of have a powerful effect. So I just want to take you through it and give you some examples of some strategies at each of these 4 steps. So the first one is reach. You know, this is the engagement topic. This is very top of mind anytime you're going to implement any type of behavior change program. It doesn't matter if you have great content, great programming, great sessions. If nobody shows up and doesn't take the first step, you can't begin the change journey. So the first R of reach, you know, one of the techniques that we've seen work well is, as David alluded to, behavioral economics. And you can see just a very simple visual example here in the bottom left corner of that slide, where in the context today, I'm going to talk about, you know, diabetes prevention and obesity reduction programming, where you've got to focus on sustained BMI improvement over a long period of time. So we develop a tailored progression for each individual that says, hey, when you get to the 5% step, Emily, here's your first reward. And when you get to the 10% step, it can grow, and kind of gamify it and make it fun and playful. And when we look at, you know, the demographics of what this can do, you know, Steve alluded to programs that only attract the healthy. We've found that you can actually reverse that. You know, our typical demographic is someone with a 34 BMI in their mid 40s for age, but very much the individual that needs to engage and try to head off something like type 2 diabetes. And a neat example of that in a very wide scale deployment that we operated across Colorado with Kaiser Permanente, where we took this to their employees, but also to the members and the residents of Colorado. Over 100,000 people joined a program to engage in this approach. And it was really powerful to see that many people kind of take that first step. But the second step of it, this retention component, is the handoff that says, reach and engagement is important, but it's not enough. It's necessary, but not sufficient to get the change we're after. And I think here a strategy to think about is shifting from extrinsic drivers to intrinsic drivers. And you need a catalyst to get their attention. That's where I think behavioral economics fits in. But then if you can shift over in the middle of this slide on the bottom, you can see an example visually of this, where we've used an approach called the healthy selfie, where to pay incentives without the expense of having a clinician moderating a weight screening, we came up with a visual scale called the Health Spot. You can see it on the far right side. We've got a workplace version and a home version that we're using heavily during COVID, but that takes a picture while someone goes through each of their screenings. And we only ask people to do this every quarter. We send that reward card every quarter, so they only have to do it once a quarter, but most people do it 12 times a year. Some people do it every week. And it shows you that we've transitioned from a health screening that you had to talk people into doing to a health screening that individuals feel like, man, this is selfishly good for me. I like seeing what happens when I invest in myself and eat better, move more, get over my barriers. So I think that's an example of getting that step toward the durable behavior change that we're after. And that program I mentioned in Colorado, we have done 500,000 of those healthy selfies across that group. So truly getting people to take control of their health and feel like they're an active participant. The third R in there is the results piece. And this is where you take that view of you can't manage what you can't measure. If we can get past some of the self-reporting, and in the context here of, say, diabetes prevention or obesity reduction, you're looking at steps, you're looking at BMI and weight. In diabetes prevention, you're definitely going to be looking at A1C levels, but trying to bring that data in brings us, I think, to this last piece of the fourth R of ROI, which is often where the sponsors or if you're an employer, the heads of the company, if you're a health plan or a health department, it could be even Medicare or Medicaid, you're looking at what are the effects of this on the economics. And I think if you can connect those dots of we're getting these powerful health benefits and we're showing what it's doing and kind of shining a light on the health challenges and the outcomes, you can really build in some sustainability. And we've had the good fortune of going through a neat study of 4 years and 40,000 people in our program and looking at measurable BMI and then the ROI from that from a payer's lens, and found a 16-to-1 ROI. Happy to share that paper if anyone wants to see it, from preventive medicine. But I think that's a type of goal that can align your program in a way to get the leadership to really buy in and keep this running for the long haul. So those examples, I focused in on just obesity and diabetes prevention, but I think you can use that for any chronic illness that you're trying to manage and hopefully trying to prevent, and have a lens to try to kind of step through it in a way that brings as many people into the program to begin with, keeps them around, and then measures the result over time. So thank you. I'll wrap it up there, David, and look forward to answering any questions on the panel.
Thank you, Todd. So we're going to try our hand here at 5 minutes of rapid Q&A response. So I apologize that we're not honoring the great questions that are coming in Q&A. And so I'm going to start with how do you make this personal? So Todd, you talked about strategies that people are embodying. They're making this intrinsic. They're making it personal to themselves for their healthy change in their behavior. I'm going to start with you, Emily. How do you get people? How do you personalize the approach to someone? And just briefly, any ideas come to mind about how you make this personal?
Yeah, I mean, one of the most important things that we do is, like I said, is build relationships. That was one of the things that I did early on, is try to have as many personal relationships with the employees to encourage them to make this part of their lives. And that's really important to us. That's why we invest in the on-site aspect of it as much as we possibly can, because that person-to-person relationship does help to personalize it. And even working with a health coach telephonically really helps to personalize it, or with a case manager. So that really helps, in addition to, kind of reeling them in through some of those broader programs like challenges or educational programs, but bringing it down to that personal level really is so important.
Steve, any additional comments about how you personalize an approach like State of Health? I know you're targeting, and we're going to get to data in just a moment, specific individuals with specific conditions, but briefly, any suggestions on how you make this personal, how you make somebody feel like they really want to be part of this program?
Yeah, that's, I mean, it's key. We really try to engage our participants in upstream thinking rather than focusing on their problems. And the health coaches are able to really interact. Health coach is going to spend at least 9 or 10 sessions throughout the year, 45 minutes to an hour sessions, plus all the groups that they can attend through the week. So we're developing that relationship, a bond between the health coach and the participant, and then also connecting participants to other participants so that they can have that social connectivity as well.
Thanks so much for bringing that up. Connecting people with one another is, I think, also really important. Cheray, I'm going to move a question over to you about how to collect data, especially among minority populations. Focus groups versus surveys. How do you consider the historical injustices around designing studies and collecting health-related information? How can companies take this approach, like you're saying, about knowing a little bit more about the individual backgrounds when it's potentially pretty sensitive history and sensitive information for people?
The first step, I believe, is just making sure everyone is informed. So different types of marketing techniques. That's the first step, is to make sure everyone is informed. And hopefully the second part is to obtain their buy-in. Making sure that they really understand the purpose of the study, what is the long-term benefits, how will it directly affect them, either directly or indirectly. And so you want to make sure they really understand the full process of why the study is being conducted, and then what's the purpose of it and long-term benefits. Along with the question about what types of surveys, if you can ever do a mixed methods approach, as far as doing a qualitative type of study where you having a little bit of your focus groups, you will find the data a little bit more robust, so you can dig a little bit deeper in some of those questions. Again, every company is different, and so the ways that you can also look at the data and have that buy-in is to have champions. Is there key minority leaders inside the workplace and also within the community that you can possibly connect with to possibly strategize and roll out the program? And so those are just some key things to kind of think about. And in regards to developing the study, it's okay to really acknowledge that, we have many minorities in the company who may not have participated in the past, maybe even starting with asking them, what would it take for you all to feel comfortable? As we, just like at the very beginning of this PowerPoint, we have the acknowledgement page. We acknowledge that there have been historical injustices when it comes to medical and scientific treatment for African Americans, Hispanics, indigenous populations. How can we make sure that as we're trying to study and create effective and culturally sensitive programming, that you all are at the table and also they feel like they're being heard?
Thank you so much, Cheray. Todd, I'm going to give you a minute. There's a lot of questions on why BMI. So tell us a little bit, like I said, briefly, before we get on to just the wrap up here, why BMI?
Yeah, thank you, David. And BMI is definitely, every method you can go through to measure someone's degree of overweight or obesity has its trade-offs, and some are much more accurate, but much harder to scale with a large population. So BMI works well as a high-level indicator for a population at a very low cost, but it definitely, I'm very sympathetic to the limitations of it and all the other the methods. You can put someone in a tank and try to measure their displacement. Hard to scale that up to a lot of people, but it's usually a good baseline measure to get someone started.
Thanks, Todd. I agree that, we're looking for scalable approaches here, right? There's, a lot of people are at work. And so there are limitations to anything that we do here. And you need to find what sticks and what works for your workforce. So I want to, once again, thank our panelists and thank all of you for joining us today. In the last minute here, talk to you a little bit about next steps that are available. We're going to be sending a follow-up email shortly in the next day or two So stay tuned for that. And we've developed a suite of diabetes prevention specific resources that we really want you to take notice of. And so you'll be hearing a lot more from Healthlinx over the next 3 months or so about the suite of diabetes prevention tools that we have available. This is one of the chronic conditions and chronic diseases that we really feel like we can make a significant impact on when it comes to prevention. So keep your eyes tuned for diabetes prevention resources specific to the Healthlinx module and to our program. And as always, we are available for consultation and advising sessions. Our next webinar is You Belong Here, a total worker health approach to inclusive engagement. This is going to be a really interesting panel. We have researchers from Accenture as well as DE&I specialists from a variety of companies to talk about being inclusive. And I think that's part of our conversation today here as well. Thanks again for all of you joining us. Thank you to our panelists today. We will leave this webinar link open for a little while to make sure you can get to what you need. There's always some follow-up emails, but we've really appreciated being able to kick off 2022 with this important conversation around the impact of chronic illness. So thanks Todd, Steve, Emily, and Cheray for your comments today. And thanks all of you for participating. I hope you have a healthy and safe rest of your day and week ahead.